Good evening, colleagues. Welcome to our new academic year Hot Topics webinar series hosted by Azra Pain Medicine in conjunction with the Association of Pain Program Directors, abbreviated APPD. I hope you had a good Labor Day weekend, and we do look forward to seeing you on our upcoming webcasts. And we will start tonight's webcast right now. And again, I welcome you. And the topic for tonight is diagnostic imaging for pain management, guidelines, indications, and interpretations. Thank you for joining us after a busy clinical day. My name is René Prescora. I'm the program director of the Multidisciplinary Pain Medicine Fellowship Program at the University of Florida, located in Gainesville. And I will be serving as your moderator and will also give one of the presentations. I'm very proud to be joined by 3 additional speakers tonight, which is Dr. Bhuvaneswari Sandeep Ram from the University of Chicago, practicing pain medicine. And I also will be joined by Dr. Mora and Dr. Jafari from the University of Florida here in Gainesville. Again, at the bottom of your screen, you see the Q&A icon. So any questions, please submit using the Q&A icon or the feature. We will go through the 4 presentations, and at the end of all 4 presentations, we will review the questions and provide live answers. Some of our answers may be answered in writing and using the Q&A icon. Again, thank you very much, and please enjoy tonight's Hot Topic webcast. And again, we will start with Dr. Juan Mora, University of Florida, and he will talk about the guidelines we have when to order imaging in pain medicine.
Well, hello, everyone. Thank you again for joining us. Thank you, Dr. Prescora, for the introduction. As you may have seen on the schedule, my duty is to use this next 10 minutes to give you some general guidelines on when to order imaging for chronic pain. As this is a big topic, then what I'll be doing is to focus mainly on spine pain and when to order those images. So I have nothing to disclose. Couple basic things first. Remember that uncomplicated lumbar pain, whenever radiculopathy or not is present, it is a self-limited condition, meaning that most of those cases are going to resolve even if we do or we don't do anything. Actually, just about 80% of the cases will going to get better within 8 weeks. With that in mind, then maybe imaging is just not necessary in the acute setting. What most of the guidelines concur on is that maybe if you let the patient with no red flag symptoms wait for at least 6 weeks for you to send an imaging, maybe that's going to be the preferred method instead of just giving the patient an imaging without any prior treatment or being just too early in the symptoms. For the purpose of this section, then we're going to divide low back pain in terms of time. The acute low back pain that they use for these guidelines are going to be less than 6 weeks of pain. The subacute will be between 6 weeks and 12 weeks, and then the chronic pain will be more than 12 weeks. The other thing to keep in mind is as well that repeating the imaging within 12 months may not show that much of a difference unless the patient has symptom change. If a patient has symptom change or that patient is going for or is needed for a surgical planning, then you may repeat an imaging. This is going to be really important. That's going to be the red flag symptoms and going to be the things that will prompt you to go for a different algorithm route and maybe actually emergently or quicker order that advanced imaging. The main thing for red flags are going to be 3 categories. One, if you're suspecting cancer. The other one, if you're suspecting a fracture. And the other one is if you're suspecting cauda equina or any other severe neurological condition. all of those trees, actually, you may just need to act a little bit faster because the faster you get the advanced imaging, you can change the outcome on the patient. Make sure that you ask the patient if they have any history of cancer, any unexplained weight loss, any immunosuppression, urinary infection, intravenous drug use, or prolonged use of corticosteroids that may just prompt you to think that the patient or the symptoms of the patient is secondary to cancer or infection. If a patient is an elderly female osteoporotic and had a trauma, then you can just suspect a spinal fracture. And of course, if a patient had any signs of cauda equina as saddle analgesia or saddle anesthesia, loss of control of the sphincters or urinary or bowel sphincters, and as well progressive weakness in the lower extremities, then of course that's going to be an emergent reason to order an advanced imaging. Routine imaging does not improve clinical outcomes and actually may expose patients to unnecessary harm. So that's why we just need to judiciously order these images only when they are necessary. They're really costly, and remember that low back pain is one of the main reasons for the patients to use the healthcare system. So if we just use imaging for every single of these patients, is going to add to the cost. They did a study in 2010 when MRI was ordered within the first month of a work-related acute low back pain, actually that was associated with a more than 8-fold increase in the risk of surgery and more than a 5-fold increase in the subsequent total medical costs compared with control patients who did not receive an early MRI. So you take an early imaging and you are exposing the patient to maybe an unnecessary surgical or an intervention. To keep in mind as well, not all the findings on the imaging equal clinical symptoms, meaning that most likely you're going to find something. Actually, whenever we felt young, 20 years old, 37% of us, we were having already some changes on the images, but that doesn't necessarily mean that we are symptomatic. Also, if you take images of an 80-year-old person, actually almost all of them, well, 96% of them will have some changes on the images, but without them having or experiencing pain. So something to keep in mind, right? Most of the time you're going to find something, but as the preferred quote for the radiologist, you need to correlate that with the clinic. There are going to be a couple of published guidelines. The two that are more related to our field are going to be the one in 2007 that the American College of Physicians, and in combination with the American Pain Society, published in 2007. And the other one that is a little bit more pertinent maybe for us and more updated is the one that the American College of Radiology, or ACR, published first in 2016, and they just updated that. Well, they updated that a few years ago in 2021. Another thing to keep in mind is the radiation that we're exposing the patients to. Of course, first of all, it's going to be MRI. There's no radiation on that because it's just a magnetic field that we're putting the patients through. Follow that by bone densitometry or the DEXA scan. That's going to be a really minimal exposure, is 0.001 millisieverts. Millisieverts is the way that we measure the absorption of radiation. Then after that is going to be the X-ray. It's going to be 1 millisievert, followed by CT scan that is about 10 millisieverts. And then the PET scan or the PET CT is going to be about 22 millisieverts, and a CT myelogram is going to be about 30 to 31 millisieverts. So keep that in mind, because you're exposing the patient to radiation. And the radiation, as we know by us using fluoroscopy, is a cumulative dose, right? That is just not only a single time and that dose will that radiation will dissipate. Actually, we accumulate that through our lifetime. First, you start with the entry one, that is the X-ray. For X-ray is just not routinely recommended in acute non-specific low back pain. It just it has a limited diagnostic value. The only reason maybe that you can use this as an entry image is if you have a suspicion of a compression fracture or a vertebral compression fracture. So it's a female osteoporotic lady that had a trauma or a chronic steroid user. Maybe you can use this for an initial workup of the vertebral body fracture. Of course, this may just not be the only image that you're going to request, because then you will need an advanced image if you have any findings on the X-ray, or actually you may miss some of the vertebral body fracture on an X-ray, but this could be used for that purpose. The other purposes for this imaging modality is going to be if you're suspecting any type of instability of the spine, and there's going to be some spondylolysis, or there's going to be some segmental motion that you can visualize. So a flexion and extension could be good. So a translation of more than 3 millimeters will be a concern for that, or a confirmation for that. Our surgeons, colleagues, they may just request a lateral bending images. That's only going to be helpful mainly when there's going to be a spinal deformity correction surgery. Remember as well, keep in mind that the radiation that we put the patients through for a lumbar X-ray is 75 times larger than an X-ray that we take for like an X-ray, a chest X-ray. Definitely just be mindful about young females, because we cannot really protect their gonads, and definitely that's just going to be really difficult to shield. CT scans is going to provide really good detail of the bone, but it's not going to be as useful for extradural soft tissue pathologies like the MRI will be. And the MRI as well will be just more specific, more sensitive for pathologies inside the canal, and as well pathologies that will involve the nerve roots or the spinal cord. It's going to be really useful for bone structural problems like spondylosis, pseudoarthrosis, fractures. It can be really helpful for posterior column fracture like transverse process, spinous process, but it's mainly of the bony structures. It can just be useful as well for post-surgical evaluation of the bone graft integrity. As well, you can just see if there's going to be any osseous fusion, and the surgeon will try to take a look at that. If that segment that they put the hardware as well have created some bony fusions or bony bridges there. It's as well going to be useful when the patient already has a hardware in place, because the MRI will give you a lot of shadows. So the CT scan can be used in that scenario as well. The patients that cannot go under MRIs, either because they have a spinal cord stimulator, they have a pacemaker, they have a hardware that is not compatible with MRI, then a CT scan can be used as a surrogate. Maybe the one with a myelogram can be giving you a little bit more detail of the central canal, as well as the neuroforamen and the lateral recess. And then actually there have been some studies that comparing the lateral recess or the diagnosis of the lateral recess compression between the CT scan and the MRI, and they show that they are similar. Keep in mind, though, that the CT scan, you're exposing the patient to radiation, and as well, you have to do an invasive procedure that is the lumbar puncture to put the contrast to make sure that you can do the myelogram. If you are going to be using any IV contrast, bottom line, you're looking for a possibility of infection of a mass or a vascular malformation. So you can use as well some IV contrast for the CT scan. The other modality that as well linked to the CT scan is a SPECT CT. That's going to be a single photon emission computer tomography. It can be used for detection of occult spondylolysis in the young patients, and as well those vertebral body fractures that are difficult to see on the X-ray, and the patient is just has no access to an MRI. As well, for hardware failure or pseudoarthrosis, it could be used for that purpose as well. MRI, of course, this is just the most sensitive, most specific for soft tissue intracanal pathologies, and it's going to be one of the preferred methods when we're going to be speaking a little bit for the guidelines. Remember, though, that the size and the type of the disc herniation and or the location they're not related to the patient outcome. So the patient can have a large disc herniation, but they can be just asymptomatic. So that has not like a really good correlation. And remember that most disc herniations are going to be reabsorbed within the next 8 weeks up to a year, right? At least 80% of those cases are going to have, if there's a disc protrusion, extrusion, or sequestrum, 80% of them are going to be reabsorbed. Delaying 6 weeks of imaging actually is not going to change the outcome. and it will not result in adverse clinical outcomes. Of course, sometimes patients really want to know what's going on, or if you consider that there's an emergency or there's an impending need for this, or there's a neurological deficit, you may just request an imaging a little bit sooner. Of course, on the other hand, please do not delay the access of an MRI or an advanced imaging if you are having, or if the patient is having any of the red flag symptoms, right? That becomes urgent if you're concerned about cancer, infection, immunosuppression, or Cauda-Equina syndrome. It is also appropriate to order an MRI if you're suspecting a vertebral body fracture, because then you can rule out the acuity. You can determine the acuity of the vertebral body fracture by the end-plate edema, mainly on the STEER sequence on T2. And as well, you can just determine the involvement of the central canal, right? If there's any retropulsion, you can determine that. MRI with and without contrast. So for us, usually MRI without contrast will be enough for musculoskeletal pathology. With and without contrast is when you are concerned, again, about an infection, a mass, a vascular abnormality, and then that will just increase the specificity and the sensitivity for infection and spinal metastasis. Just be mindful, though, that you're giving a contrast and it's gadolinium-based contrast. So patients that are with GFR less than 30, it's actually contraindicated because can be they can have an adverse reaction that is a nephrogenic systemic fibrosis that can create a good amount of damage to the kidneys and to the other organs. And as well, remember that there's an FDA notification in the past recent years that this gadolinium-based contrast can just accumulate in our body for months or years before being excreted. With this one, actually, with and without contrast, you can have some advantage over just with the without contrast. For the post-surgical patients, that they can help you to determine if a disc herniation is a residual disc herniation, is a recurrence of a disc herniation, or it's just a scar tissue, right? That can just help you to determine with and without contrast. And as well, it can help you to evaluate nerve root compression or arachnoiditis, right? So for the post-surgical patients may have some value as well. So this is going to be the first guidelines. I'm just going to put one slide for this. It's from 2007. So pretty much what they say is that we should not routinely order images for non-specific low back pain. Non-specific low back pain means pain that it just, without any radicular symptoms, it just axial low back pain. The other one is that, sure, whenever there's severe progressive neurological deficits or any serious underlying conditions are suspected, you can order an advanced imaging. And the third point that they said is that if the patient has persistent low back pain, and only if they are potential candidates for surgery or an epidural steroid injection, then you can order an advanced imaging. I think that these guidelines, they're not as specific as the American College of Radiology. So I'm just going to put that slide for those guidelines there. But now we're just going to go into the American College of Radiology guidelines. This is going to be mainly the color code that they're going to be using for their statement. Green, of course, is like the traffic light, right? So green is fantastic. Yes, use it is appropriate. Yellow, maybe yes, maybe not. And they did not reach like a full agreement on the recommendation of this modalities or imaging modalities. And the red one is just not recommended. Sorry. They as well put some of the radiation exposure. One thing to be mindful about is that, of course, there's going to be the non-exposure, but as well they group on the same category the range between 1 and 10 millisieverts. Remember, the radiograph or the X-ray is going to be around 1 millisievert, and the CT scan is going to be around 10 millisieverts. So they group them on the same category. So they just came and say, okay, we understand that there are different type of patients, and there may be going to be different situations that require different type of images. So why don't we create like 7 different variants? The first variant is going to be the acute low back pain, meaning the pain that has been less than 6 weeks. With no red flag symptoms and no prior management. The second one is going to be the pain that has been already more than 6 weeks with no red flags, but the patient has not received any treatment, any conservative management. The third one is already a pain that has lasted more than 6 weeks, and the patient has received already conservative treatment. What to do in that situation? And then after that is going to come the complicated cases, or the one that require like a little bit more attention. There's going to be the one with the red flag symptoms. But the fourth variant is going to be the one that you're concerned about, cauda syndrome. The third one is going to be a patient with a prior lumbar surgery. The sixth one is going to be a patient that you're concerned about a vertebral body fracture. And the seventh one is going to be that you're concerned about cancer, infection, or immunosuppression. So the first variant, that is the acute pain, less than 6 weeks with no red flag symptoms. Actually, none of the imagings are going to be recommended. So you don't need to order an X-ray, a CT scan, an MRI. They're just not appropriate to be ordered. The variant number 2 is going to be the pain that has already passed the 6 weeks, but the patient doesn't have any red flag symptoms, and as well, the patient has not completed any conservative management like physical therapy, massage, medications like NSAIDs or other modalities of treatment. Then actually that is still not necessary, the imaging, and the patient can wait until they can try those modalities and see if they can improve on their own. The third variant is going to be the pain that has lasted for over 6 weeks. There's no red flag symptoms, but the patient has already attempted at least those 6 weeks of conservative management, and then the patient has or not radiculopathy. Then actually what they recommend first is an MRI, right? So they say an MRI may be just the most appropriate test for you to start to discern or to see what's going on with the patient. The other ones may be appropriate. So an X-ray may be appropriate, and an MRI with or without. Remember, it's going to be mainly for infection, cancer, or vascular abnormality that you will use the with or without contrast. The fourth variant is going to be the one with the concerns of a cauda equina. In that case, if you think that it's just mainly because of a herniation or like a structural issue there of the spine, that is not an infection or a cancer, then an MRI without contrast will be the first option. If you're concerned about cancer, or that this is secondary of an epidural abscess, like an infection, and then the patient is having cauda equina, then an MRI with or without contrast is going to be actually better for that patient. Of course, the patient that cannot have access to this, that you make, or they have a hardware, that you may consider doing a CT scan for that purpose. The other images are just not appropriate. The fifth variant is going to be the low back pain with history of prior lumbar surgery. In this case, actually, what they said is all the ones in green, you can actually combine them, because maybe the MRI is not going to give you all the details about the hardware. So you may just order an X-ray, maybe a flexion and extension, and as well on top of that, an MRI, right? Because we know that with an MRI, we will have a lot of shadows, and we may not be able to assess the level of interest. So in this situation specifically, you may combine more than one imaging modality. But it's mainly going to be radiographs are okay. You most likely are going to need to combine that with either an MRI or a CT scan. It just depends of the physician decision. But usually MRI is going to be far superior to that. Remember that the MRI with and without contrast in a post-surgical patient may help you to determine if the compression is secondary to a disc material or to a scar tissue material. And as well as going to be able to help you to determine if the patient has arachnoiditis. And a CT scan will not help you with that. And variant 6 is going to be the one that you're concerned about osteoporosis. So there's a history of a low energy trauma with a patient that has high risk of osteoporosis, either female menopause or chronic steroid use. This one as well, you may need more than one imaging. The radiograph could be the entry imaging. This is the only case that they are okay with the X-ray as an entry imaging. And then you may just order an MRI or a CT scan. It just depends on the patient. The CT scan will give you a good amount of information on the posterior column and on the bony structures, but it will miss the soft tissue and the central canal information. So usually the MRI will give you a little bit more information about the acuity of the vertebral body fracture, as well as the integrity of the elements in the canal and the nerve structures. And the last variant is going to be the one that you have a suspicion of cancer, infection, or immunosuppression. Actually, with this one, an MRI with or without contrast is going to be the image that is going to be recommended. If you don't have access to that, then an MRI without contrast could be beneficial as well to determine the involvement of the cancer and the spinal metastasis. The other ones could be prescribed. Radiograph, they didn't really had too much of agreement on what to do with an X-ray for cancer purposes. So they just listed that there's a disagreement. And CT scan could be useful, but it will not give you as much of detail as the MRI. All right, and with that, hopefully you get a little bit of a brief introduction of what to do and when to do. And that is the American College of Radiology guidelines that you can review online. The last update is from 2021.
Juan, Dr. Moore, thank you very much. This was an excellent introduction. And again, this is an important aspect to provide evidence-based patient care, so you can explain your decisions to your patients. And you also can communicate, for example, with the insurance carriers who more and more do play a role in approving your image studies and following that, your treatment plan. I already see questions coming in. Again, please use the Q&A feature. And it's my pleasure to introduce Dr. Bhuvaneswari Sandeep Ram from the University of Chicago, Department of Anesthesiology. And Dr. Sandeep Ram will talk about central canal, neural foraminal stenosis, but also epidural abscess, pelvic mass, and erector spinae wasting. Again, welcome, and we will start our second presentation for tonight.
Good evening, everyone. Are you able to see my slides?
Yes, perfect.
Okay. I'm Bhuvana Sandeep Ram. I work as a faculty at University of Chicago. No disclosures, no off-label product drug used. I'm going to cover the indications and interpretations in central canal stenosis, neural foraminal stenosis, epidural abscess, pelvic mass with focus on leiomyoma endometriosis, and erector spinae wasting or paraspinal muscle atrophy, called as PMA. Obviously, all these topics are very vast. So we are going to talk about the following images: X-rays in certain situations, CT, MRI, which is gold standard, and I don't have any 3D MRI, but 3D MRI has been used in certain situations, like assessing the L5 transforaminal views. CT myelogram, and then not as an imaging modality, but nerve conduction studies can be used as a investigational modality as well. So coming to spinal stenosis, majority of it is acquired, most likely degenerative trauma, any systemic pathologies, or iatrogenic post-surgeries. The congenital variants, the most common ones are short pedicles, achondroplasia, thoracolumbar kyphosis, or any spinal dysraphisms. In the cervical, thoracic, or lumbar, it can be central or neural foraminal, and the lateral races stenosis happens only in the lumbar spine. So you would see the patient in the clinic with pain, neurogenic claudication, any myelopathic, radiculopathic symptoms with sensory disturbances, motor weakness, or any abnormal reflexes. So here we start with flexion extension X-ray, as we just saw that the role of X-ray in evaluating these situations are minimal, but when it comes to evaluating a dynamic instability, we still go with a flexion extend imaging. I also saw there was a Q&A question regarding how do you evaluate the dynamic instability? So there are multiple parameters. First, we see a sagittal translation where there is a slippage of one vertebrae over other if it is more than 3 millimeters. And as this picture depicts, the angle at extension and angle at flexion are measured, and if there is a difference between these two angles more than 10 degrees, it is also considered to have some amount of dynamic instability. And there is a tangent which is drawn to the angle, and a slip percentage is calculated. So with the slip percentage, you get, if it's less than, it should be at least more than 8%. And based on that, they do grade 1 less than 25, grade 2 25 to 50, grade 3 is 50 to 75, and grade 4 more than 75%. The role of CT scan, mostly fractures after trauma, pre and post-surgery comparisons, any guided diagnostic procedures like abscess, aspiration, to rule out congenital anomalies of the bone, to assess tumors, or bone density assessment. Just as we discussed, the CT myelogram in evaluating lumbar spinal stenosis, mostly when the patient has any MRI unconditional devices like pacemakers, stimulators, or MRI is having a great deal of artifacts like spinal instrumentation. So here we go for the interpretation of how we quantify central canal stenosis. So there are qualitative and quantitative measures and different grading systems that are available. The AP diameter of at least less than 10 mm and cross and 100 millimeter square for the lumbar. Luries is the most common. Luries and Lees are actually the most commonly used, but there are also other grades such as Shizas, which is a 7-point grading. Grade 1 has 4 A, B, C, D, and then like 2, 3, and 4 grades are available. And Miskin-Mandel is again a 4-point grading system. So Lurie's grading for central canal, grade 1 is no stenosis. Mild or 2 is when there is a compromise of the total central canal less than 1/3. Between 1/3 to 2/3 is moderate, and severe when it is more than 2/3 of area compromise of the central canal. So here we go. This is the Lee grading for assessment of central canal stenosis. If you see the picture, first picture A, where there is no obliteration of the space, and you can see the individual equina very clearly. The mild stenosis, the picture B, there is some obliteration of the space, but the cauda equina roots are still individually seen well. The third picture on the lower left is moderate stenosis, where there is obliteration and also some clumping where the individual cauda equina roots are not able to be appreciated very clearly. 4 are severe, where there is severe obliteration, compression of the dural sac, and there is no differentiation between individual cauda equina roots. So this is for the central canal stenosis. This is the same grade as we discussed. And this is for the neural foraminal stenosis. So the picture A is normal, where you see fat layer and CSF all around the foramen. And this is done at the level of the subarticular, where we are able to see the foramen and the nerve root exiting. So the grade B, grade 2 is picture B and C. So there is obliteration in one plane, either the transverse plane or the vertical plane. Figure B shows the obliteration in the transverse plane, and figure C shows the obliteration in the vertical plane, where we are not able to see the CSF. The moderate is the picture D, where there is obliteration in both the directions. Both transverse obliteration is seen, and also the vertical obliteration is seen. And figure E, that is the severe, where we don't see any free CSF flows, and there is morphological change and collapse of the nerve root. And this is similarly grading. This is for the cervical central canal. In this, if you see the figure A, there is normal, no obliteration of the subarachnoid space. B is mild, where there is obliteration of the subarachnoid space, interrupted flow of CSF, but there is no cord abnormality or no cord compression. Moderate is in figure C. There is obliteration of the subarachnoid space, and also there is a cord compression, but no signal abnormalities are seen. This is severe cervical central canal stenosis, which is figure D, where we see the obliteration of the subarachnoid space. There is cord compression, and there is also intracord signal abnormalities are seen, like cord edema, which is indicative of chronic injury. And these are the grades for cervical neural foraminal assessment. If you see the figure representation, the blue, the nerve root and the foramen size are seen. When there is no compression of the neural foramen, the nerve roots are seen full, where the foramen is larger than the nerve root. When the foraminal size is 50 to 100% of the nerve root, it becomes a non-severe neural foraminal stenosis, as in figure B. If there is a severe neural foraminal stenosis, as in figure C, the foramen width is more than 50% less than the actual nerve root size. So this all belongs to, this is all Lee grading, and this is probably one of the most common grades used as per the RSNA Society. Moving on to second topic, epidural abscess. The incidence is about 0.2 to 0.8 per year, peaking at higher age group. Staph aureus is the most common pathogen. Posterior abscesses are more common, which is 80%, and anterior abscess. Cervical is 15%. The maximum incidence occurs in about thoracic, and lumbar is about 35%. The most common symptomatology is patient with back pain and fever who is immunodeficient or a recent surgery or trauma that is possible. So as far as the anterior abscess, it is most likely associated with discitis or vertebral osteomyelitis, whereas posterior epidural abscess could be seeding from a very distant dental, which is the most common source, and it seeds onto the epidural space. So this is a T2 image of the epidural space. Figure A is obliteration of the epidural space, thickening, and shows the abscess, whereas in comparison, B is a normal thecal space without any compression of the cord. The figure 5 is obviously there is peripheral enhancement and inflammatory tissues surrounding. So the figure 5 shows like the posterior abscess also extending all around and covering. I just realized that the video is off, so just turning it on for a second. Our third topic for today is any pelvic mass, most commonly the leiomyoma causing low back pain. Any gynecological conditions causing low back pain, where patients come with typical lumbar radiculopathy with a negative MRI. So most of these are hormone associated, perimenopausal age group, where the symptoms are cyclical in nature. Endometriosis is the most common cause, but fibroids, pelvic inflammatory disease with a tubo-ovarian abscess or a retroverted uterus, all these can cause low back pain. Whenever the MRI lumbar spine is negative, in this kind of a clinical scenario, it is imperative to think about the gynecological conditions and get referred to a gynae services and go ahead with a US abdomen and MRI pelvis to see if there is any compression of neural structures. There have been case reports of pelvic mass pressing on an individual nerves So this was one of the case who was referred to our pain clinic, pretty similar age group, cyclical pain. So this is a tubo-ovarian abscess pressing on the L5 nerve root and patient presenting with typical L5 radiculopathy. This is in summary of all extravertebral non-musculoskeletal conditions which can cause lumbar radiculopathy symptoms. Moving on to the last topic, paraspinal muscle atrophy. This is still a debate whether the paraspinal muscle atrophy causes low back pain, or it is somebody with a low back pain has become deconditioned so that the muscle goes into atrophy. When it comes to evaluating the paraspinal muscles, all three multifidus, the two muscles of the erector spinae and psoas, they are all evaluated for muscle atrophy with the reduction of cross-sectional areas and the amount of fatty infiltration within the muscles. Out of these muscles, multifidus, the innervation is unisegmental. So it's at the same segment as the exiting nerve root, whereas erector spinae is multisegmental. So if there is a unilateral atrophy and fatty infiltration of a single level multifidus, it is supposed to correlate with a disc bulge or herniation at the same level compressing the exiting roots. Again, MRI is the gold standard to evaluate, and typical evaluation includes the cross-sectional area and the fatty infiltration. So for the fatty infiltration, it could be a qualitative assessment versus Gautelier's classification. The Gautelier's classification is not limited to the paraspinal muscles, whereas it was originally reported in shoulder, and it slowly expanded to all the muscle assessments wherever the atrophy is being graded. So 0 is no fatty infiltration with few streaks. Grade 2 is less than 50%. Grade 3 is more than 50%. 50%, and grade 4 is more than 50% of fat within the muscle. And the other quantitative cross-sectional area, as the regular figure suggests, it's all done in T2 weighted MRI. All the assessments which we discussed so far, the standard is to do it in the T2 axial and then the T2 sagittal cuts. So the cross-sectional area is measured, and then there are two parameters that are derived: the muscle cross-section to that particular level vertebral body cross-section, and the lean cross-sectional area to the overall cross-section areas. Thank you, and open for question answers.
Good afternoon.
Thank you very much for the presentation. And Amir, it's your turn. Thank you very much.
Thank you. My name is Amir Jafari. I'm an assistant professor at University of Florida. I'm going to go over some of the diagnostic imaging and pain medicine. All right, some basics of MRI to go over real quick. On MRI, usually we compare T1 and T2 images. Fat is bright on T1 and it is dark on T2. CSF is bright on T2 and dark on T1. The way I remember it is that CSF, water, H2O is bright on T2. Spinal cord is dark both on T1 and T2. And STEER, which will come up later, stands for short-cut inversion recovery. And when you obtain a contrast imaging, you want to compare T1 with and without contrast. As Dr. Mora mentioned, this contrast imaging could be used to evaluate for abscess, infection, and other pathologies. And here's an example of a T1 MRI. Fat is bright. As you can see, these little fat marks right here, these are the epidural space fats. And spinal cord is dark here. And CSF is as well dark. Different shade of darkness here. And ligament in the front, this would be the anterior longitudinal ligament. And then behind the vertebral body would be the posterior longitudinal ligament. And the disc also is dark on T2. I'm sorry, T1. Now, as we go to T2 MRI imaging, The big difference is the CSF. As you notice, the CSF is bright and fat is bright. And sometimes if I'm planning out an interlaminar steroid injection, I go and make sure that there's some fatty in the space here for my needle placement if I'm really concerned about the stenosis in that area. All right, so one of the pathologies I'd like to discuss is motor changes. That's become a very hot topic nowadays. And there are interventions out there that does help with this pathology. Signal changes in the vertebral body end plate and bone marrow is what modic changes is. Basically, the end plates are these. This is discussing modic changes in the vertebral body. The vertebral body look like tuna can, what I say, and the end plates when there is degenerative disc disease, disc herniation, patients that smoke, spinal cord deformities like scoliosis, even genetics. These can lead to inflammation in the end plate of the vertebral body, the end of the plates, either superior or inferior of these end plates. That can lead to inflammation, and inflammation can basically lead to activation of the nociceptor pain receptors, which can activate the nerves and send a signal to the brain, signal pain. Now, there are 3 types of modic changes, 1, 2, 3. Type 1 is when there's fibrovascular tissue thickening at the end plate. This usually shows up bright on T2 and dark on T1. So this is dark on T1 and bright on T2. And you see, this is the end plate. This is the vertebral body, and this is the end plate where the disc is right between the 2 vertebral bodies that meets, and that basically the disc is in contact with the end plate. So when you have degenerative disc disease, some of these disc material can leak into the end plate and activate that inflammation. The inflammatory soup will come in and cause that pain. Modic type 2 is a fatty marrow replacement of the bone, and this will show bright on T1 and T2. So type 2 is bright on both of them, T1 and T2. As you can see, this patient has degenerative disc disease, and you see the disc material basically slowly creeping into the end plate and activating the inflammatory process and causing inflammation and leading to what we call a vertebrogenic pain, which has a very specific presentation. And then there's type 3, that's both dark on T1 and T2. And this is what it looks like. All right. So vertebral bodies are innervated by the basovertebral nerve, which is a branch of the sinovertebral nerve. This is what kind of looks like. The sinovertebral nerve gives rise to the basovertebral nerve that covers these end plates. And this nerve has become a target of a specific procedure. Now we can actually ablate these nerves by putting a radiofrequency probe in the center of the vertebral body and creating a very large lesion that can actually ablate this nerve and basically provide significant pain relief to the patients that are experiencing pain from the vertebrogenic pain. Now, as I said before, it's the actual activation of the nociceptor pain receptors by the inflammation, chronic inflammation that leads to the pain generation. All right, the next pathology would be compression fracture. Again, I have 10 to 15 minutes, so I'll try to go not to go into too much of a detail with these. But the compression fractures, it could be acute or chronic. The acute fractures are very painful, and usually chronic, slow chronic fractures are not symptomatic. Now, pain may be tolerable or incapacity based on how acute or chronic it is. Slow osteoporotic fractures could be asymptomatic, patients that have severe osteoporosis and slowly they lose height in the vertebral body and the vertebral body starts collapsing. Usually these patients have localized tenderness over the spinous process or even the paraspinal area where you can actually, figure out where the level is and push on it, and they will jump because you can easily reproduce the pain. And some of these patients can have retropulsion. Retropulsion is when you have a compression fracture. Basically, that vertebral body is compressed and a piece of bone sticks out into the spinal canal and that basically compresses the spinal cord. That's what we call retropulsion. And acute pain usually resolves after 4 to 6 weeks, but it may last longer, and that's when you need the interventional pain procedures to come in and help. Each complete fracture can lead to approximately 1 centimeter in height loss in these patients. So now if you have 2 or 3 fractures, you can see why the patients can actually get shorter with them. Now, if you have 4 centimeter height loss, that's equivalent to 15 degrees in kyphosis. So it can truly affect the physiology of the patient. Right. So majority of the compression fractures are caused by osteoporosis. Now, there are other differential diagnoses: hyperparathyroidism, hematologic diseases, infection, metastatic cancer that can travel, metastasize to the bone, osteomalacia. This could be the cause of the compression fracture. And the way we rate the compression fracture, grade 1, 2, 3, 20 to 25% height loss would be grade 1, 25 to 40% grade 2, and then greater than 40% grade 3. Now, this percentage usually is basically reported on the MRI report or the X-ray report. They compare the normal side compared to the collapsed side and tell you how much height loss you have. Treatment option, usually if you see a patient, you want to start with bracing, give them a brace. And if it's an acute fracture, oral analgesia, start with NSAIDs, acetaminophen. Calcitonin is a great option, another name for the salmon. And what it does is basically helps harden the bone, so it helps with pain, these patients. And then the ultimate treatment, if the compression fracture is not healing with conservative management, it would be the vertebroplasty. Here are some of the examples of the different types of compression fracture. We got the wedge fracture, and this would be type 3 wedge fracture, where the front of it is wedged in. There you have the biconcave fracture, as the center of the vertebral body is caving in, both from the top and the bottom here, as you see. And then you have the crush fracture. It's one of the most difficult ones to treat with the kyphoplastic procedure. Here's an example of a compression fracture. As you can see here, 12 days after trauma. There's another image. So this is basically initially immediately after trauma, and then on the right you see there's an adjacent segment collapse. So if you don't catch these patients early and put them in a brace, it can continue fracturing the neighboring segments, because the whole physiology, the anatomy has changed. So there's different pressure points on these vertebral bodies now. So you gotta definitely make sure that they are wearing that brace. Here's a great example of retropulsion. As you see, there's a bony structure sticking out and basically compressing. There's significant compression on the spinal cord, and the rootlets are being basically shoved into the posterior part of the spine and causing nerve compression and edema, nerve edema. So this definitely needs immediate neurosurgical evaluation. You know, this is not a procedure that is a candidate for kyphoplasty, because if you try to balloon this up, you can worsen that retropulsion and push back any posterior structure even more. Now, you know, some of the treatments for vertebral compression fracture would be kyphoplasty, balloon kyphoplasty, where basically place a balloon in the center of the collapsed vertebral body and balloon it up and then fill that with cement. But a new intervention, no, it's not so new, but we've been using, it's been very effective. It's called a spine jack, where you basically place these two skis, these two jacks. It basically looks like a car jack. And once it's placed in, it's jacked up. And as it's jacked up, it creates this cavity in the center, and then that center is filled with cement. As you can see, this area, one of the advantages of this procedure is that it really can provide a great height gain. Again, trying to restore that height loss, as you can see here, the difference between the top preoperative and postoperative. And another advantage based on the reporting is that this will spine jack reduces the risk of adjacent segment fracture. Imagine you have these three soft bones here from osteoporosis, and the middle one collapsed. Now you go and put a sphere-looking cement in the middle. Now there's increased risk of fracturing the top or the bottom one because we've hardened the center one. So spine jack, theoretically supposed to reduce the risk of adjacent segment fracture. Now, another pathology is multiple myeloma. And this is a multifocal, basically perforation of plasma cells within the bone marrow. The clinical presentation is they come in with bone pain in the spine. There's marrow failure. They have anemia due to reduced red blood cell counts, infection due to reduced white blood cell counts, hypercalcemia from constant breaking down of bone and release of calcium in the blood. Now, treatment for this, again, analgesia, basically NSAIDs, acetaminophen, other medications. Conservative treatment would be bisphosphonate. This will help reduce the breakdown of bone by inhibiting osteoclast, its activity. Erythropoietin will help increase, red blood cell production, local radiation, chemotherapy, even bone marrow transplant. Here's an example of that, changes you'll see on the MRI. Another example, as the texture of these bones, they, definitely has a distinct look to it on the MRI. DISH stands for diffuse idiopathic skeletal hyperostosis, and this is usually involves the anterior longitudinal ligaments. Again, the vertebral body is surrounded anteriorly by the anterior longitudinal ligament and posteriorly by posterior longitudinal ligament. When you have four contiguous vertebral bodies fused by ossification, when there's osteophytes that attach these vertebral bodies anteriorly, that's when the diagnosis is made. Now, again, right in front of this structure is where you have the esophagus and the trachea. So if it's pretty severe, then these patients develop difficulty swallowing, and it can be pretty painful. And so that's when they would be a candidate for osteophyte resection by neurosurgery. But vast majority of them are actually treated by conservative treatment. Here's an example of the ossification in the anterior vertebral body. As you can see in front of it, there's the other structure like the esophagus and the trachea. So as it gets bigger and becomes more sharp, it can actually compress on those structures and create that difficulty swallowing. And the ossification of the posterior longitudinal ligament is the other pathology that is involving the posterior longitudinal ligament. The PLL is the structure that separates the spinal cord from the vertebral bodies. It's a very thin ligament that actually, sometimes when if you do a transforaminal thruster injection, you will see the contrast light up right in front of this ligament. Possible, so if this structure gets really thick from calcification and osteophytes form, this can create a pretty significant compression on the spinal cord and cause myelopathy if there is severe stenosis. So asymptomatic patients, you just observe them, and yearly imaging, it's really non-operative management, conservative treatment. But if they have, they're symptomatic and they have significant stenosis, then corpectomy or laminectomy, decompression is needed by neurosurgery. Again, this is the anterior longitudinal ligament, and this is the posterior longitudinal ligament. And here, as you see in front of, behind C3, C4 area, you see that it's pointing out and it's compressing the spinal cord, and you could see some edema on the cord as well there, signal changes. Hemangioma is an incidental finding. A lot of times we see it on MRIs. It is a common benign venous malformation within the vertebral bodies. And, typically we just find it incidentally. It is very well, it's a hypodense lesion that has a white polka dot shape to it. And on CT, on MRI, again, they are hyperintense on both on T1 and T2. Usually, we don't do anything about them. Now, one thing to think about is that if you're, planning on proceeding with the kyphoplasty or intercept procedure, you're putting a pretty large trocar or working tube inside the pedicle, which gonna end up in the vertebral body. So if you have these large venous malformation and you put this large tube in there, you're going to see major bleeding. So you want to do, pay attention to this and plan this, have a good pre-surgical planning. Again, if it's very aggressive hemangioma, then embolization and surgical resection can be the ultimate treatment for it, even radiation therapy. Here's some example of it. All right, thank you.
Amir, thank you very much. And I think I'll move ahead with the last presentation of tonight's webinar. And again, it's diagnostic imaging for pain management, guidelines, indications, and interpretations. And I will be talking about the lumbar disc herniation and epidural hematoma. You already heard about epidural abscess from Dr. Sandeep Ram, so I will talk about epidural hematoma. Those are my disclosures. I have no financial relationship to the topic I will present tonight at our webinar. And again, these are my headlines: spinal epidural hematoma and lumbar disc herniation. So let's talk about spinal epidural hematoma. So you heard it from Dr. Moore about back pain and the red flags, which determine an immediate evaluation and not a follow-up in just 6 weeks. So what could it show up like? So there is a new neurological deficit, and that can include in the back pain, but again, we're talking about deficits, so also in the extremities, it can be sensory and or motor functions. They can be progressive. You can have saddle anesthesia, when you think about the perianal area, if this becomes numb, you're going to have an anal sphincter weakness. And again, if you consider there may be a severe neurological compromise, you have to do certain exams, including, the rectal digital exam to assess the sphincter tone. What is a spinal epidural hematoma and how does it happen? So per definition, the spinal epidural hematoma is a collection of blood in the potential space between the dura and the periosteum. It's usually venous in origin, and the etiology, again, it can be spontaneous. That doesn't mean anything has an intervention done. So example, when the patients are on anticoagulation, they can develop spontaneous epidural hematoma. And then on top of that, if they have a bleeding disorder, if they have multi-organ dysfunction, so if you think about the platelets are affected, hypersplenism, liver cirrhosis, which affects the clotting factors, and hopefully not, but let's say there is also an indication for a blood thinner or anticoagulation, it can worsen the situation. Trauma, obviously, and then of course call it iatrogenic or procedures, surgeries, or injections done by our surgical colleagues, or let's say by us pain physicians. So if you think it is a spinal epidural hematoma, it's an emergency. When remotely considering it in your thought process, or I should say unprofessional approach, like your belly feeling tells you, you should order imaging. You should initiate a diagnostic cascade, and you should not just do a follow-up. The hematoma can expand over several segments, so there is an indication that you may have to image the entire spine. So keep that in mind, even though you may have done an intervention at the lower spine, upper spine, but also definitely if it is sort of a spontaneous epidural hematoma, if there is a coagulopathy, consider imaging the entire spine, or if you have focused on one region which didn't yield any results, consider expanding the field you're looking at. spinal epidural hematoma, what diagnostic images would you use? Again, sometimes I have to say expedite imaging is of the essence, so you may tailor an intervention to preserve further loss of function or to may help the patient to restore function. So sometimes, a lot of times, you come in the ER first is a CT, as a non-contrast CT. You would see an hyperdense extradural mass. Now, again, the MRI is the recommended diagnostic tool, and the signal characteristics of an epidural hematoma will vary on the age of blood because it undergoes changes, and that will reflect on the appearance on an MRI. But again, sometimes, like I said, consider expediting things. Most ERs have a CT scanner available. MRIs may take longer, or there is limited access. So if you have to, my advice is don't delay the diagnostics. So again, the MRI is call it the best, or if you have, recommended diagnostic tool. The signal characteristics, just to give an example, will vary the age of blood. So we'll see here, so if you have a hyperacute within 24 hours, you're going to see, for example, the blood will look like on T1 hypointense, on T2 hyperintense. Now, when you have let's say, a chronic spinal epidural hematoma, let's say especially patients who are on anticoagulation, which is more than 2 weeks old, you're going to see the hemosiderin is the component you're going to basically image, and there it will change from T1 and T2. Both will be hypointense. So just that you keep in mind that the appearance of the blood product on an MRI for spinal epidural hematoma will change with time from hyperacute, 24 hours, to chronic, which is over 2 weeks. So spinal anatomy, again, what is what, which spaces are we looking at? Sometimes we get confused, or we're all busy and working a lot. So you see figure 1, which is the sagittal T1 view, and you have the markings, with the names, you see the intermedullary space, the subarachnoid space, the subdural space, and then you see the epidural space. You also see the epidural space where there is the fatty tissue, if you recall from the previous presentations, including, the ones from Dr. Jafari. Now, on the axial T2 image, again, you see, the different spaces in which you can find blood products. Here, we're talking about specifically the epidural space. So let's move along. Let me see, I have to move something away here. Okay, and this, again, depicts an MRI, and you see a sagittal view, and you see an axial view of a T1 and T2 weighted images. And you're going to see this is the lumbar spine when you look here, and this is the main topic of this presentation. And you're going to see basically there is a signal intensity, there's sort of a mass effect. And if you recall, just comparing the previous slides, you're going to see this is located in the epidural space. Again, you see the sagittal view, you see that it can extend over 2 segments. Again, it's not the entire spine here. And then also, if you look at the axial images, those are pictures C and D. You're also going to see the epidural blood product in the epidural space. It's like a sign, like a ring sign, depending how much it is expanding. All right, now we're moving to the next topic. So we had the epidural hematoma. Now, obviously, you can have a spinal subdural hematoma, and that is what, by definition, just as a comparison. So this is a subdural hematoma. There's a blood products which occurs in the potential space between the dura and the arachnoid mater. Again, by definition, usually this space, some anatomy doesn't exist. But again, those are 2 layers connected. There is blood supply in between and passing through. So blood products can accumulate in the subdural space. If that then becomes a space, and this becomes a hematoma. Again, those are the images here. So again, you can depict on the axial view and on the sagittal view here. For comparison, obviously, you see the cervical spine when you look at the spinous processes and the projection of the laminars, especially on the also sagittal view. And you're going to see again the arrow pointing at a dark matter, a structure, expanding again more than one segment. And then you also see adjacent to it, you see the spinal cord, and you see there's compromise, especially if you scroll up and down to the adjacent segments. And you're also going to see the epidural space, with the signal. And you're going to see that when you look at the axial images, especially, you're going to see that in part the CSF flow is obliterated. Sometimes it makes it also difficult to distinguish CSF and from the blood product. So again, you see pictures here, A and B on the axial images. Again, normal epidural fat, if you recall Dr. Jafari's presentation, can be helpful to establish the anatomic area where the blood products are located. So, for example, that it is not the epidural space, that it can be the subdural space. Again, spinal epidural hematoma, let's say you do not have an immediate access to an MRI and there's severe progressive neurological deficits warranting an urgent, maybe surgical interventions to preserve or maintain function. You can see the blood products and the space occupying effects. And again, that leads finally also to the neurological deficits on a CT scan, on orienting non-contrast CT scan, again, especially if it is acute, especially with acute onset pain, progressive pain, and progressive neurological deficits. You're going to see a hyperdense extradural mass, again, which is not located within the dual space. And here you see sagittal, and you also see axial CT scan images, again, non-contrast, and you see the hyperdense, again, acute blood products. And then especially when you then look at the sagittal view, you see that it is expanding over several segments. These are the image findings. Let's move along. Topic number 2. The last topic for tonight's webcast. This is lumbar disc herniation. I have to disclose for the timing, I was not able to incorporate, for example, cervical disc herniations, thoracic disc herniations. At times, we will use different classifications at this spinal levels. But to understand the basics and where you see most of the herniations and most probably you're going to treat first as a fellow or upcoming pain physician, it will be in the lumbar spine. So let's talk about lumbar disc herniation, and you understand the principle, which you then can expand to the other spinal areas. So lumbar disc herniation, you heard already from the guidelines when you're going to order imaging. Again, those are just a few indications. Again, symptoms, pain not improving, neurological deficits, again, because you may want to plan a different treatment, not expecting it may need the surgical interventions, because if we delay it, we are too late, the deficit will not recover. If we don't know what is the diagnosis, so if there's a concern, there's a deficit, is it a disc herniation, as the patient has other risk factors, immunocompromised, a recent trauma on top, or a surgical or pain intervention. For lumbar disc herniation, the preferred imaging technique is MRI. Again, you can also see it on myograms. You can use CTs, again, in patients who cannot undergo an MRI for various reasons. For example, they have certain implants, including ENT or hearing implants, or, if they have some of our older, let's say, stimulator components. So the MRI is preferred, but there are other options. If you don't know, based on the patient's condition, which type of imaging to order, or with or without contrast, rest assured you are not the radiologist. Those are the experts you're going to consult. However, you need to help your colleague to suggest, or at least discuss or mention in your order, what do you suspect of, so they can make the best decision. So sometimes they know to use contrast or not just based on the question or concern you have. So be specific if you can, or what is your concern. Just don't write in there it's back pain. Then that just may just do, I call it the routine, and your patient unfortunately wasn't the routine. Moving along, now you're going to hear, we're talking about disc herniation, you're going to hear the terms bulging discs. Your patient comes in, you're going to hear, let's say herniated discs. So what are the differences? So again, there's a few definitions if you go in the literature, and sometimes about all evening presentations, again, you will find information and also definitions and examples in the radiology literature. So it's not just the pain literature, but also it is the radiology literature or the literature of our spine surgeons, so you can communicate at the same level. So they accept you as, I call it, a professional who knows what you're talking about. So one definition about bulging disc is a generalized displacement of the disc over 25% of the circumference of the disc. So symmetric or asymmetric, but it's more than 25% involved of the circumference. Now, what is a herniated disc? Again, this is localized or focal displacement of disc material of less than 25% of the disc circumference in the axial plane. Again, those are two definitions you can use to distinguish bulging from herniated disc. So herniated disc, less than 25% of disc material affecting the disc circumference, and you're going to do that in the axial plane. All right, let's move to the next slide if I can. Here we go. And you're going to see here, this is a busy slide. You're going to see it later. And again, this is actually an image out of our current very common recommended textbooks. This is edited by Dr. Benson. He was a very well-respected pain physician, or is in Chicago. And again, for comparison, you see the normal disc up in the upper left. Then you see a diffuse disc bulge. Again, it involves more than 25% of the whole circumference of the disc. And then when you go to the right, the upper image, you're going to see a broad-based protrusion, which involves, when you see the gray structure, 25 to 50% of the circumference. Now we're going to go in the middle section. And at the left, you're going to see there's also disc material sort of moving away from the regular position. And when you would measure it, this is under 25% of the circumference of the disc. This is called, for example, a focal protrusion. Focal protrusion can evolve, or initially it can also just start as an extrusion, depending on the biomechanics working on the disc. And then you're going to have an extrusion. And then the extrusion, you're going to measure the diameters A and B. A is close to the disc connected, and if B, which is further away from the disc, is larger, wider than A, you can call this a disc extrusion compared to a protrusion. Now, the next term is sequestration. So sequestration basically is the definition is there is disc material which is no longer in contact with the call it parent disc. So it is completely separated from the disc. When we look at the lower line, you're going to see the sagittal explanations, about disc bulge, the protrusion. You're going to see how it expands, and then you're going to see extrusion. We talked about the diameters, and then in D, which is on the left, on the right lower bottom part, you're going to see disc material in this schematic, which is no longer in contact with the parent disc. Again, this is available online or in our literature, but like I also said, consider the radiology literature. So we can further define where is the disc herniation, what's going on, where to may do a transradial epidural steroid injection, or how to explain while you have a herniation at a certain level, but it doesn't correspond with your radicular symptoms. So they may be above or below when you look at the imaging. So this can be in part explained the relationship between, again, we're talking lumbar, so most likely cauda, equina, and then the nerve roots, how they're going to exit to the foramen. And when they start separating from the cauda equina, traveling into the foramen and then exiting basically the spinal canal. So here, when we look at the left, again, that's from my view, you're going to see an axial cut. You're going to see there's the central canal zone. It looks sort of orange. Then you have sort of a pinkish zone. This is the subarticular zone right next where the facet joints would be located up until cephalad and caudate. Then you go into the foramen. This is the green underlaid area. That's the foraminal zone. And of course, you can have an extraforaminal zone, lateral zone, you know, when you have a herniation basically pointing outside the spinal canal. Now, this is an axial cut. Now, if you then look at the adjacent image, again, you understand better maybe the correlation between the symptoms and response where the disc material is located. So when you look here, we're going to see again, there is a suprapedicle level. That's when you look with the green letters, you see it can be a herniation at the pedicle level. Now, obviously, you would say there is no disc, but remember you have protrusions, extrusions, or even a sequester. So disc material can go there, can end up there, and can create a nerve irritation or deficit. Then you have the infrapedicular level, and then, of course, you have the disc level at the bottom level. So those are the one levels. If you go craniocaudate, and then you can go from medial to lateral. So those are the blue named zones. And again, you have the central zone. If you compare to the right on the axial cut, then you have the subarticular zone, you know, where you see you could have individual nerve root. And then you go in the foraminal zone where you would have the corresponding nerve root irritated, you know, and then you can go out far lateral. You have the extraforaminal zone corresponding to the spinal nerve exiting. So keep those two pictures in mind, especially if you have to make a decision which level, or let's say if you do a transforaminal abduction, you're going to inject when you feel, or maybe your patient tells you, I have read for 5, you did something 5-1, or vice versa, so that you understand where the disc material is located to the best of your judgment, professional judgment, and which irritation it is causing, and where to gonna put or place your maybe therapeutic or maybe also diagnostic intervention, either so we can help the patient or we can help out our surgical colleagues and further define if a surgery would be beneficial and then at which level. Again, here you see it again, just because I feel it is important. You know, you're going to see the craniocaudate levels, and then on the right, you're going to see again the, call it medial to lateral levels. You're going to see the central zone, the subarticular zone. You're going to see the correspondence to the cauda, to the nerve roots, foraminal zone herniation if you see a disc material in this area, and then the extraforaminal zone where you would get the nerve, the exiting nerve root or plexus, depending how big your herniation is. How does it look on the images? So here we're going to have an MRI. We're going to see on the far left, this is a sagittal view, and then we're going to see 3 axial cuts or slices, we call that. Now, when you look at L3-4, you're going to see that the disc lights up very nicely. It has good fluid in there, so it looks relatively healthy on the sagittal view. If you go to the 4-5 and 5-1, if you would assume it has, the patient has 5 lumbar vertebral bodies, you're going to see they're more darkened, and you're going to see that there is material, or the darker structure, the disc material is expanding behind the usual limits of the disc. Now, if you then look at the images B, C, and D, the axial cuts, we're going to see again, B is the level 3-4, which looks normal. And again, sometimes it's difficult to say what is normal, so combine different views of the MRI to make that assessment. Then if you look to image number C, which is the L4-5 disc, you're going to see that there is a central protrusion, which is lapping into the spinal canal. But if you look at the foramen or the extraforaminal zones, subarticular zones, they do look okay. Now, for comparison, again, B is normal, C is the central protrusion, and then we're going to look at D, and you see there is still a central, but it's more pointing towards the right. So there is a right central extrusion with caudal migration if you scan to the axial planes, or if you then take for your assistant the view of the sagittal view, where you're going to see that the disc material, I don't know if you can see my pointer, is migrating downwards or caudal. So that can also explains the different locations, which nerve root it gets contacted at, and where you may have to target your intervention. All right, I'll move to the next slide. Here you see some more images, and this is more like, all right, I'll move this away. You see cut number E, which is on the left. Now you're going to see a left-sided sequestered disc fragment contacting the thecal sac. And if you then look at image number F, and here I think number G, that's what I would like to highlight. So the image number G, which is middle to the right, you see that this is fat saturated and suppressed, and you're going to see the inflammatory reaction, the white structure around the sequestered disc material. If you look at image number E, you would say, yes, it impinges, when you look at F, and then when you see basically fat suppressed image number G, you're going to see this is the inflammation going around, and this is not an infection. So you understand that there's irritation. You understand that this may also be an indication for a steroid injection to assist with the inflammation and the swelling, which irritates itself, but it's also because of the swelling space occupying. So you see those images. So we're moving along. I think I have just a few more left. Again, this is actually interesting because we're talking about disc herniation. So to be fair, you can have findings on your images. That doesn't mean that the patient is symptomatic. So as a physician, my advice is don't just make a treatment plan just based on images, definitely not something invasive. So you will see multiple changes a lot of times as our patients get older, and it's your professional knowledge and skill set to tease out which level is actually given the problem, or sometimes it is more than one. I do agree, but again, just don't go by the image. Again, talk to the patient, see where the pain is, where it is most dominant. So what do we see here? So we see a sagittal view on the right. We see axial cuts at J, and then again another sagittal view K, and another axial view on L. So this, when we just look at I and J, again, we're going to see, again, if you compare it, the disc material just compared to the other one, again, the 4-5 and 5-1, they don't look healthy if you compare it to the others. You see there is disc material beyond the normal disc location. If you then look at the axial image, you're going to see there's a central towards, I would assume, what does it say? The left, depending on the labelings, you're going to see that this disc material herniation will irritate S1 and L5. Now, this patient apparently has had a herniation previously at 5-1, which you see here. And when you see the follow-up images, you see this herniation has resolved. So again, if you look here, an eye, you see it. If you then look at the follow-up, I think this is, don't want to lie, 4 years later. Again, they had a herniation at a different level. You see again, K and L, you see that this material is resolved and there was no surgical intervention. So changes in our spine are dynamic. Just don't operate or jump on it just because you see there is something pushing in. Again, it depends on the symptoms, the neurological deficits. And yes, this herniation can resolve. There's a theory that it may happen more in the lumbar spine compared to the cervical spine, because the cervical spine disc herniation, disc material apparently has a tendency to calcify, so which means it may will stay there like concrete. So keep that in mind. But things can change, especially if the patient asks you to. This is my presentation about epidural hematoma. Yes, we touched briefly subdural hematoma and lumbar disc herniation. And I think for the disc herniation, it's more important to understand caudate, cephalad location, and then medial to lateral locations, which would explain the symptoms and can help you with your therapeutic intervention. So this is the end of our fourth presentation. I think our panelists will be happy to open up the camera again. And also now we're running out of time. And let's look at the few questions again. Does sequestered disc material tend to migrate? We'll take the last one. Short answer is yes, it can. I would be unfair or say it never migrates. So it depends how relatively new you feel comfortable your imaging study is, or if you plan, let's say, especially in advanced intervention, even a surgery, and the patient reports symptoms have changed. So the disc material can migrate, or the sequester. More can get herniate, so there's another option. You can get on top of that maybe a new herniation at a different level, so it can be dynamic. So if you plan an intervention, and let's say the day of the presentation of the intervention, symptoms are changing, you can be maybe suspicious that you have to discuss with the patient that there may be an indication to update imaging, or if you proceed that you may have to be aware about the potential outcomes, or that maybe more needs to be done because it is a dynamic change can happen. So I would say we come to the end of tonight's presentation, and I appreciate you all staying on. And I know it sometimes is a topic and dry material we have to cover, but that is important. So if you understand certain terms you have maybe heard the first time, but if you can incorporate them the way you communicate in your notes, you know, it will help you with your professional standing, with your referring colleagues, especially if you're an interventionalist and, you know, you're talking, for example, to your surgeons and neurosurgeons and radiologists, so that we all communicate at the same level, make the best decisions. That said, again, thank you very much for everyone joining, I guess, after a busy day. And thank you all for the panelists, Dr. Mora, you know, Dr. Jafari, and especially Dr. Sandeep Ram joining us from Chicago. So we have North and South combined tonight to get you all in the middle. And again, on behalf of Azra Pain Medicine and APPD, I'd like to thank you. And I would like to invite you to join us again on Tuesday, November 5. So Tuesday, November 5, the 5th of November. And we will talk about radiofrequency techniques. There are many techniques out, and we will focus on the spine care. That means facet structures and vertebral bodies, for example, basovertebral nerve, like with Dr. Jafari already touched tonight, you know, the mobic changes which you need to understand to make good decision. I also would like to encourage you to join Azra Pain Medicine, the fall meeting this year. Again, it's an excellent society, very supportive, you know, of our specialty and you of the next generation. That said, I'll say thank you, everyone, and have a good night and a good, hopefully shorter week then.